Right, hello, Marvel nerds and DC geeks. My name's Danny Whitaker. This is my own worst enemy, mental health podcast. I'm not going to make a meal of today's introduction. Can't even speak. My little boy's got his cousins round at the house. It's chaos. We just had a newborn baby a few weeks ago. She's seen her ass all day long. Got kids running around the house causing chaos. Dogs are barking. And if that wasn't bad enough, we've just been daft enough to go and stuff our faces with like these big Oreo milkshakes that are like full of biscuits and cream and chocolate sauce, and so I'm already feeling groggy off it, and I know that in about 5 minutes time I'm going to have to curl up into a ball and cry myself to sleep before I slip into a diabetic coma. So anyway, let's crack on. God, I sound well moody. I promise the episode itself is a lot more chipper and upbeat than this. Come on, lad. Sort yourself out. Right. Today's episode, the topic is bipolar disorder, also known, or formerly known, should I say, as manic depression. My guest today is Professor Stephen Jones. Stephen is Professor of Clinical Psychology at Lancaster University, where he is also Director of the Spectrum Centre for Mental Health Research, conducting translational research into the understanding and psychological treatment of bipolar disorder and other related conditions. He's the editor and author of a number of books, including Coping with Schizophrenia, a guide for parents, families and caregivers, and Coping with Bipolar Disorder, a CBT-informed guide to living with manic depression. So, what is bipolar disorder and how does it differ from plain old depression? In this episode, we untangle the various manifestations of bipolar, including bipolar types 1 and 2, and cyclothymia. We discuss the nature and duration of mood swings and what triggers them. We examine the concept of mania and manic episodes and how these affect people's thoughts and behaviours. We also explore something called mixed affective states, where the person basically experiences depression and mania simultaneously, and why this can increase the risk of suicide in people with bipolar. We discover why both adolescence and middle age are times when people are particularly susceptible to the onset of bipolar, the causal link between sleep deprivation and mania, the controversial topic of bipolar in children and whether or not this actually exists. We discuss treatment options, personality variables, issues of cultural context, and loads more in between. You can follow Steve on Twitter. He's at Lancs Spectrum. That's at LANCS Spectrum. If you'd like to comment on this episode, you can do so by going to myownworstenemy.org/podcast. If you enjoy this podcast, you have been enjoying this podcast, and you'd like to help me in my efforts to expand and grow it, there are various ways you can go about doing that. Just visit myownworstenemy.org/support. And what I'm going to do now is go crawl into bed and try and sleep through what I can already feel is going to be the worst sugar rush I've had for the past 10 years. And just hope that the kids and the dogs don't kill each other in the meantime. And while I'm doing that, as I always say, please enjoy my conversation with Professor Stephen Jones. Right, okay, Steve Jones, welcome to the podcast.
Thank you.
So, our subject of discussion for today is bipolar disorder.
Mm-hmm.
It's one of those subjects which, on the face of it, seems to me a very, two things, a very stigmatised mental health issue and a very misunderstood one with, say, the general population. For me personally, I'll drop the stigma aspect, but it's not something I know anything about, or very little about.
Yeah.
And so the reason I haven't over-researched coming into this interview is I think that the misunderstandings that I possibly have and the lack of knowledge that I have are probably quite representative of the general public.
Yes, no, I'm sure you're right. Yeah.
So just to let the audience know that's where I'm coming from.
Okay.
So I think it'd be good to actually start. Before we do any of that, I'd like to know a little bit about you.
Okay.
I'd like to know a little bit about your academic career, your trajectory, and how this came to be your speciality specifically.
Okay, so I've been sort of working in this sort of area for quite a long time now. So I first started doing work around bipolar disorder in probably the early 90s. And that was, I was working with a group of people at the Institute of Psychiatry in London. And it was, in a sense, one of those conversations. I'd been working with people with psychosis, and I was talking to a colleague who was working with people with depression. And we were just talking about that, and then we were sort of saying, well, what's happening for people with bipolar disorder? You know, we've got these people with a range of symptoms, and no one seems to be doing very much for those people. And so once the idea had formed, we started, you know, talking to people with bipolar about what they wanted, and it just seemed a huge gap. Here were people with an enormous amount of potential who, with the right levels of support, can do lots of great things, who didn't seem to be getting very much support. So I think both the gap in terms of support and just the whole area of bipolar disorder, I personally find fascinating, because these are people who have, as I say, so much potential, so many talents, and so many challenges at the same time, that it's a sort of area that kind of draws you in. So that's kind of, you know, although I work with people with a range of mental health experiences, bipolar has been a kind of key focus for a lot of what I've done for a long time.
What's the, just for you personally, what's the particular kind of area of interest? Why is it that bipolar is particularly interesting as opposed to, say, generalized anxiety or depression?
That's an interesting question. I mean, I think I've always been particularly interested in, for want of a better word, the severer end of mental health problems. And in a way, that's a terrible generalization, because I know that, you know, whatever the particular diagnostic label somebody has, you can have lots of very extreme experiences within those. But my career started off focusing on psychosis. So I was interested in people who have experiences that include things like hallucinations and delusions and that sort of thing. And but within bipolar disorder, people can experience some of those things. They can also obviously have periods of major depression. They can experience severe anxiety symptoms. And they can also, you know, as I was saying, achieve great things and, you know, be really high-performing people in the workplace. So in some ways, the fascinating thing about bipolar disorder is that it sort of almost covers all the bases in mental health, from, if you like, anxiety at one end to you know, paralyzing depression potentially for some people at another, and all the points in between.
Right, well, that's the kind of perfect summary to get us started, to help people understand the complexity of it. So now, if we kind of take a step back right to the basics now, and if we can define bipolar, because apparently we have bipolar type 1 and 2, and then something called cyclothymia.
Okay, so there are a range of diagnostic criteria for bipolar disorder, and I'll say a bit about those in a minute. But I think what I'd like to say first is a bit of a health warning on diagnosis. So although people can find the experience of diagnosis helpful, other people find it less helpful. And what it is really is a shorthand for summarising a set of experiences for people. And I think where it comes unstuck is where it's seen as a sort of an entity of itself that defines a whole set of potentials that the person has. And that's when it becomes unhelpful. So just to give you an example, if you look at tendencies towards bipolar disorder in the general population, you find that there's lots of people who don't meet diagnostic criteria, who have lots of bipolar-like experiences. And so the dividing line between the general population and somebody who might meet diagnostic criteria is more of a quantitative one, in the sense that it's when those experiences are escalating to a point that it's causing you a problem, or somebody else a major problem. So with that caveat in mind, bipolar disorder generally is characterized by the experience of periods of very elevated mood, when you feel very kind of driven and potentially excited. You don't feel like you need sleep. You feel often very positive about your ideas, so you kind of have really big plans for something, and you're not really in tuned to possible risks or difficulties with those. You can find other people very irritating and slow, that they're not keeping up with you. And people often find that in periods of mania, there can be a pleasurable element to that it feels exciting and positive, and then quite often people will find that it goes a bit further, and then they feel sort of agitated and irritable and stressed, but still really driven. And so that can feel a lot less pleasant. And then people also experience periods of depression, so feeling low, feeling bad about yourself, to the extent sometimes, that you're really struggling to get going, getting out of bed, just not feeling like life is worth living. And most people with bipolar disorder experience both of those elements. And in bipolar 1 disorder, it's when you've got experience basically of full mania. So changes in activity levels and mood, where your mood has escalated to the point where you're really not functioning properly. There are substantial difficulties with your functioning compared to normal. So, your ability to sort of look after yourself is compromised. Your ability to make good choices in terms of risk is problematic. At the episode level of it, people aren't able, they're not able to maintain their current work and that sort of thing. And often with full mania, people are admitted to hospital.
Okay.
Then bipolar 2 is very similar in profile, but the big difference is that people there are only tending to experience hypomania. So hypomania is like a scaled down version of mania, if you like. So people get mood elevation. They might be getting significantly more optimistic and positive. They might need less sleep. They're feeling, more driven. But it's not that they've gone to the stage where their functioning has really suffered as a result of that. And in fact, for some people, being in a state of hypomania rather than mania can be something that feels really positive. And, in some cases, people talk about having done really constructive things in that phase. So the difficulty with hypomania is its instability. If you're in a position where that doesn't trip into mania, then that could be something which is actually quite a positive for you. But if it's an unstable thing that trips you towards mania, then it's a kind of risky place to be.
Right. Okay. And what's cyclothymia?
Cyclothymia is basically an experience where somebody's having periods of their mood going up, periods of their mood going down, but they're never quite getting to the point where they're full episodes of depression or full episodes of mania. So it might be that they're having highs or elevated mood for shorter periods of time. So for mania, you need to be in that elevated state with the change in functioning for a period of at least a week. So if you're having it for briefer periods, or it's not quite so severe, and then your mood's dipping into lower mood, that's more like a cyclothymic pattern. So you're getting these phases of elevation and depression without being fully depressed or fully manic at any point in that.
Right. So, okay, let's explore the episodes themselves a little deeper, because, well, just on the face of it there, it sounds that more like what makes bipolar distinctive is the episodes of mania as opposed to the depressive episodes. That's the most distinctive feature. So let's use the kind of stereotypical image that people have of bipolar, and that is that somebody with bipolar, they cycle through these moods almost on a regular basis. So the other distinction being that, so let's say, member of the general population, everybody has cyclical moods.
Oh yes, certainly.
So we all feel down,
Yep.
and we all feel great sometimes.
Yep.
But what's different about bipolar is the downs are extreme downs and the highs are extreme highs.
Yeah, that's a good summary. Yeah.
So what about the actual periods of the episodes? Is it a constant cyclical nature? So you're depressed and you go up and you go down and you go, and there's kind of no respite from it.
Yeah, that's a really good question. So I think one thing to say is that so you've got this group called people with bipolar disorder, and within that the categories you described and we've just talked about, but within those people vary a lot. So there are some people who may have had only 1 or 2 episodes of mania and a couple of episodes of depression in their lives, and there are other people who may have had 30, 40, 50 episodes. So there's something called rapid cycling bipolar disorder, where people sort of have quite frequent periods of mania and then depression, mania and then depression. But for a lot of people, they do have patterns where they have both, but they also have periods in between that when they're definitely not in an episode. I mean, one of the challenges with treatment is actually trying to support people in between those extreme episodes, because sometimes people might not be in a depressive state or a manic state, but they might have some symptoms of both, even though it's not an episode. And those are, just living with those can be quite a problem when you're trying to get on with your life.
Could we give any kind of, because these are very kind of abstract terms like mania and depression, could you give any kind of concrete examples of, well, I suppose the best expression of mood is behaviour. So kind of concrete examples of how somebody might behave in an episode of deep depression, also in mania, but also how the behaviours might escalate and how quickly that would be the case as well.
Yeah, okay. Well, so in general, when people are depressed, they're struggling to function in a sense because they feel bad about themselves, they feel negative about the world, and they feel pessimistic about what's going to happen next. So the normal things that get us out of bed in the morning, thinking tomorrow's another day, or, I've got some interesting stuff to do, or I'm looking forward to seeing my friend or my partner or whatever, most of those things are flattened out by depression. So you don't particularly think your partner wants to see you anymore. You don't particularly feel that seeing other people will affect your mood. You don't really feel you have anything to offer. You don't really feel that if you put a lot of effort in, you'll get a good return. So instead of feeling, we all have a bad day. I don't know. You go to work, something goes wrong, it feels a bit grim, and you think, well, at least the day's over, and another day tomorrow. If you're depressed, then something goes wrong at work, and that feels like the end of the world. It feels like you have failed in some enormous way, that everyone else thinks you're an idiot, and that you have no redeeming features, and that there's no way out of that situation. And it's easy to imagine if that's where your mind's going, then actually taking yourself out of the workplace, taking yourself away from other people can seem what you need to do. So you can end up quite isolated. You don't feel you can go to work. You don't feel other people want you around, or that you can't sort of almost benefit from them either, because nothing's going to help. And you can end up, as I say, in quite an isolated position around that.
Is it, say, a deeper episode of depression than somebody with just depression might experience? I know this is very generalised, but do you know what I mean? Just in keeping with this idea that somebody with bipolar tends to have more extreme lows and more extreme highs. Somebody without bipolar, if they experience depression, it would be of a less intense kind than somebody with bipolar disorder, because it's almost as if the person with bipolar disorder is kind of hypersensitive to those mood changes, maybe.
Well, that's an interesting and quite complicated question, so I'll do my best. I think I wouldn't feel comfortable saying that in the round, in general, people with bipolar disorder have worse depression than people with depression, because it varies such a lot in both. So I've seen people with major depression who are paralyzed by it, and I've seen people with bipolar who are depressed who are paralyzed by it. I've also seen, all the variations of that. So I mean, I think your point about the contrast is an important one, because obviously people living with bipolar, like the rest of us, are living as human beings with all the experiences, not just the particular one they're in. So I think that the sense of being in a low mood when you know what it's like to be in periods of elevated mood, and that contrast is something people are aware of, yes. And, if you think about, for most people with bipolar disorder, they have more periods of depression than they do periods of mania on average.
Okay.
And so some people do end up almost trying to find ways of stimulating their mood up towards a more hypomanic level as a relief from the depression.
And what about some like concrete examples of the episodes of mania? So how is somebody going to behave? Some real world scenarios that people maybe tend to get themselves involved in during that episode.
I think one of the things you were saying, in a sense, behaviours is one of the ways of talking about it. So if I think of, I'm just going to, for confidentiality purposes, I'm going to slightly fictionalise something, but it's an example that I could think of from a while ago. So, because I think in general, when you think of people with mental health problems or the experience of mental health problems, it's often around distress, and it normally is. But when people are going up into mania, most of us wouldn't necessarily say there's somebody with a mental health issue at that point. So to give you one example, there's somebody with an interest in music that I worked with quite a long time ago. And when they were entering a period of elevated mood, they'd be the most convincing person in the world. So they would be able to sort of ring up booking agents that they normally couldn't get to answer them, and they convinced them that they were about to get investment from all sorts of places that would allow them to play venues that they couldn't normally access. And that could get to the point where they were formally taken on. And that's the problem is that the mania itself is unstable and doesn't carry you through. So by the time all of that had been resolved, the mood had changed, and they might have been in a state of depression by then and not able to do it.
So I'm just wondering if some of the other behaviours I've read about are things like kind of reckless spending, and kind of reckless sexual behaviour.
Yes.
Is there is it an element of the person's kind of character and personality that gets magnified during a sense of mania, or can it be that person? So take the well, I think the reckless sexual behaviour is a good one, because there's danger in that, real danger in that. Would it tend to be that maybe somebody's quite flirtatious in general, and then during a period of mania, that would just become magnified, and then it spills over into reckless behaviour? Or could it be that someone is very conservative, usually, between an episode, and then during mania it completely changes their personality?
Yeah, so the answer is, in a way, both, in the sense that for some people, changes in mania they would probably themselves say that they're like amplifications or exaggerations of how they would normally be. But it's not uncommon for somebody's behaviour in mania to feel really foreign to them, and to be almost doubly distressing when they're thinking back on it. Because there are definite examples of people who have, in general life, very conservative and, have very strict moral compass about, say, sexual behaviour, if that's the example, who may in a manic episode have been, got into a sexual relationship with a stranger or something. So not only it might that be physically risky in a range of different ways, depending on the person's vulnerabilities, but also, as I say, mortifying afterwards, because it feels like such a sort of difference from how they would see themselves in general. Yeah.
Is there any kind of, when a person's experiencing the mania, because in depression, part of the depression is that kind of metacognitive awareness that this isn't a place I want to be in, that I feel like I'm suffering. But in a period of mania, if you're feeling like, I feel amazing, I can take on the world, is there any awareness on the part of the person that, I feel amazing, I feel like I can take on the world, but this probably isn't, there's something going on here, or are they completely blind to that?
That's an interesting one, and I think often people are sort of operating at two levels with regard to that. So at one level, there's the sense of drive and optimism, and this is great, and at another level, there's a sort of an awareness that I'm sure I've been here before, and I'm sure it didn't end well. So there is, a tension between those. And I think there are different stages, as we were talking about, in going into mania. So there's the beginning bit often feels really positive. And then as it develops, that can continue for a while. But then, you start getting to feel more on the sort of agitated, irritable, exhausted end of things, because maybe you've been awake for 3 days and working without breaks, or whatever you're living with, you're only human in the end. And so quite often what can sort of tip somebody back out of the mania is just the system runs out of steam, really.
Just sheer exhaustion. Wow. Is there any typical duration for the periods of depression and mania, and for the periods of kind of respite in between?
Yeah, I mean, on the whole, periods of depression seem to be on average longer, and that's reflected in the diagnostic criteria. So the minimum period for an episode of mania is a week, but it can go on for, weeks up to months. People could be in a depressive episode again for weeks or months. And the experience of bipolar disorder, as I was saying, is quite an individual one and varied from person to person. So some people may have, a manic episode followed by a depressed episode, and then may have, a year, 2 years, 3 years, no episodes at all. Other people, may have 1 or 2 episodes a year. And people can also find that changes sometimes in their lives. If they're in a unstable situation one way or another, that can often be associated with, more vulnerability to episodes. And then, being in more settled circumstances, people can often, have longer periods of being well or out of episode.
Is that the same for the episodes of mania as well? That could go for weeks or months at a time?
It's a very unusual months, but weeks. I mean, because it's so exhausting, it tends, and it's hard to give a definitive answer on what it naturally would look like, because it's in the nature of mania that you draw attention to yourself.
Yeah.
So mania is one of those things where sometimes people are, I don't know, walking naked down the street or that sort of thing, or getting into arguments with passers-by. And so people in mania often come to the attention of either clinical services or the police, often taken there by family or friends. So you don't need to have that, be in that state for very long before somebody's taken you somewhere, right, and you're given, hospital treatment with often significant levels of medication, tranquilizing medication. So that's why I'm slightly hesitating about the exact duration when it's mania. Okay,
before we move on, I think one last thing that would be definitely worth mentioning. So a mixed affective episode, which is apparently a period of depression and mania simultaneously.
Yeah.
Can we explain that? That sounds very counterintuitive.
It's some people experience this mixed affective state, which is where experiences of mania and depression are sort of mixed together. So it's actually an interesting and very distressing sort of state for people, I think, in the sense that as you posed the question, it sounds like you're taking two polar opposites and putting them together in a way.
Yeah.
And so you could have somebody, for instance, who has the sort of drive and energy and focus that comes from the mania side of things, but a feeling of not liking themselves and not being optimistic that comes from the depressive side. And that tension can feel really, really difficult. So in bipolar disorder, there are risks for people, in terms of self-harm and suicide and that sort of thing. And the mixed affective state is one of the states that's one of the more risky ones for that, because you've got the mania elements, meaning you might be more prone to taking risks, and the depressive elements, meaning you're feeling that it's not, things aren't really worth pursuing.
Wow, yeah.
And so you can see that that's potentially quite a dangerous mixture for somebody to live with.
Is that a typical experience for someone with bipolar, or is that a rarity?
Not everyone experiences that. So it's not a rarity as in something that's hardly ever seen. But there are plenty of people with bipolar disorder who don't have that. But it is a neglected area in terms of looking at optimal ways of helping people. And I think that partly reflects that there's a lot of work to do in terms of improving what we can do for people with bipolar, because it has been neglected, and that means there hasn't been as much research on that area as there has on some other comparable areas.
All right, moving on. If we could kind of give a kind of a brief overview of the basic epidemiology, like things like the age of onset, the kind of gender disparities, if there's any interesting patterns with maybe ethnicity, different cultures, things like that.
So I think in terms of bipolar disorder, the onset is usually in sort of late adolescence, early adulthood. So which is often very sad, really, because somebody's just reaching sort of a state of kind of independence, just beginning to get on with their lives, and then they get hit with this thing which, you know, can compromise that quite significantly. So in terms of men and women, there really isn't much evidence that there's a substantial difference between men and women in terms of frequency of bipolar disorder. So it seems fairly equal across the two. In terms of, there have been a number of sort of international studies looking at rates of bipolar disorder across countries, and when they all use the same measure, which wasn't the case in some of the earlier studies, when they all use the same sort of criteria, if you like, then the rates aren't that dissimilar across countries. And I think, I mean, in terms of different cultures, I think one of the complexities is looking at the sort of manifestations of, say, manic behaviour in different cultures. So I had, for instance, a Saudi PhD student really interested in bipolar disorder, and his work over there was the sorts of things people were doing were very different to the sorts of things that were happening in sort of Western culture. So being quite, you know, in the early stages of mood change towards manic mood, people are often sort of more definite, more assertive, possibly more aggressive verbally, more insistent, less willing to listen to other people. And if you imagine that sort of the beginnings of that behaviour in a more collectivist sort of culture where it's supposed to be about the group more than the individual, then the tolerance for that is often lower, was the sort of suggestion from what he was saying from his experience over there. So
whereas like an investment banker in New York,
it would possibly get him promoted.
Wow, interesting. I remember when I was doing we've covered psychosis with Alison Young in a previous episode, and she said that with psychosis, there's, after a certain period, say you get someone into like the mid-30s, you'd be looking for kind of physical causes for the onset of psychosis. And I'm just wondering if that's the same with bipolar disorder, like you were saying, the onset tends to be during adolescence. Is there a time when, you know, you reach maybe 30, 35, what's the word I'm looking for? I was going to say you kind of inoculated from it.
Do you mean if you hadn't had it by then, you wouldn't have it?
Yeah, possibly. Is there a time at which, you know, if apparently bipolar-like symptoms can be caused by certain neurological disorders. So I'm just wondering if that's the same as with psychosis, or can it pretty much come on at any time?
Just to take the different elements of that. So you're right that you can mimic some symptoms relevant to bipolar disorder through brain insult or drug use or various other things. I think it's an important question as to the logic of whether that means that's the same thing. I'm not necessarily sure it is. I think one of the things that holds back research in mental health is almost a false dichotomy between, you know, a biological explanation or a psychosocial explanation. And so I think there's the sort of thinking of those more as different levels of ways of understanding something rather than competing theories, I think is often I feel is a helpful way forward, because clearly, you know, whatever we're doing happens in our society, in our behaviour, and in our heads, really. So having said that, so onset of bipolar disorders, as I was saying, in young adulthood, but there are people. There's almost like a secondary bulge of onset of bipolar disorder in later life as well. So there are people who are in their 50s and 60s who develop bipolar disorder then.
Is there any kind of hypothesis as to why that is?
Well, I think I mean, in some ways, if you think about it, they're two major change points, aren't they? One, late adolescent, early adulthood. There, you're trying to establish yourself and independently. There's a lot of things that may trigger sensitivity to things that would drive you. Leaving home, starting a career, starting a degree, getting a degree, starting a family. All of those things are happening around that time. And one of the psychological theories around bipolar disorder is that people who develop bipolar are kind of overly sensitive to signs of situations that might be rewarding, and very driven to dig those out and find those really mood enhancing naturally, and that then sort of, once that ball is rolling, then achieving things through that. They don't reach a point of what's been called coasting. So normally, if you or I, say, had a series of 3 or 4 successes, you might. Well, I would tend to think, oh well, that's good.
Right.
That's probably enough.
Yeah.
Whereas in bipolar, it's more sort of, right, well, let's go bigger and better and bigger and better and bigger and better.
Right.
So that can be applied to lots of aspects of life. But when you're in a period of change, like when you're trying to define yourself as an adult, for instance, that's one. And of course, in 50s, 60s, you're sort of, there are other big changes. I mean, I don't know, divorce, retirement, bereavement, loss of parents. There's a lot of different things happening there as well.
Existential crisis.
Yep.
Yeah.
What have I done with the last 50 years?
Yeah.
All of those things. So I think, contextually, it sort of makes some sense that those would be the periods with the peaks, I think. And one of our researchers here is Lizzie Tyler, is doing some really interesting work working with older adults with bipolar disorder about their problems. So, because within bipolar disorder generally, older adults are a particularly neglected group.
Well, that's a good segue into this next question, which I believe is quite a controversial topic, about the existence of bipolar disorder in children. Any opinions?
Yep.
Okay. Care to explore them?
Yes, certainly. So I think one of the real problems around bipolar disorder in children is around the overlap between things that you would characterize as bipolar symptoms and things that you would characterize as being a child. So a number of the things we've talked about around mania are about sort of elements of drive, elements of being impulsive, elements of risk-taking, elements of not necessarily listening that much to other people, and so on. I mean, if you go through the list, it does read quite like, what it's like to go through adolescence in some ways. So there are a number of childhood sort of, behavioural difficulties like conduct disorder and attention problems that aren't bipolar disorder that are also associated with these things. So I'm not convinced that it's particularly helpful to think of, younger children and bipolar disorder. That's my view.
Yeah.
And also, there isn't a great correlation between apparently having bipolar disorder as a child and whether you have bipolar disorder as an adult. The literature is really mixed on that. So also from a sort of empirical data-based point of view, one doesn't seem to predict the other in any way in as strong a way as you would want it to if you were going to label a child with something as sort of potentially challenging as that sort of diagnosis. So the NICE guidelines for bipolar disorder, it basically focused its guidance primarily on adolescents upwards in terms of bipolar disorder. And that seems to be a reasonable compromise to me.
Okay, so I'd like to move on to some of the causes now. And we've talked about them a little bit. And in all the conditions we've kind of talked about so far, the idea of life stresses, particularly around adolescence, they seem a very ubiquitous explanation. Yeah. But I'd like to kind of skip over them because they're kind of obvious and they seem to be a factor in every mental health issue. What kind of interests me about bipolar in particular is, can't help but suspect that there's some sort of I don't like the chemical imbalance term. I'm not keen on that term. But there's something going on at a neurological level that is... I'm just going to leave that there. I'm just going to hand that over to you and see whether there is anything specifically neurological going on that's identifiable with bipolar.
Well, you see, I think that's really interesting, because I think one of the challenges with bipolar has been that it has traditionally been seen as almost self-evidently a genetically defined kind of biological disorder. And that's actually been one of the things that's really hampered psychological research and psychological therapy research. Our findings are that, as I was saying earlier, people, if you look at tendencies towards bipolar disorder, they're distributed throughout the general population. So if the argument is that it's basically a neurological flaw, it's one that's shared by quite varying degrees by pretty much all of us, really, and therefore is not in that sense distinguishing. So I think a lot of the sort of personality research suggests that we all have, if you put all of us under enough pressure one way or another, something happens. And for some of us that may be drug problems, for others it may be bipolar, for others it may be psychosis, and so on. And so there certainly are sets of experiences that people have that seem to be relevant. So, for instance, there is evidence that bipolar disorder runs in families, and that has historically been taken to be genetic evidence.
On the face of it, it does seem so. So, I mean, just to kind of cover this for people, is talked about in the past how the argument of like heritability with depression, and so a mother in a family is depressed, and then there's a high chance that the children are going to suffer from depression as well. But then so you don't know whether to take that as there's a genetic component, or whether growing up in that environment has predisposed the child to it on kind of a behavioural level, if you like.
Precisely. So if you take your the discussion we had earlier about context, yeah, I mean, what's a more powerful context than the environment you were brought up in? So if you think about if you're a parent who has bipolar disorder, you have two conflicting challenges, really. One is parenting, which is, in a sense, as we all aspire to as parents, is trying to provide your kids with a loving, sort of safe, secure, and somewhat predictable environment where, if you do, so actions have consequences that you can predict as a child. So you learn the way things work in a safe place. So you've got that on one hand, and then you've got living with instability of mood on the other as a parent. So that's pulling you in a different direction, because it's really hard to be sort of consistent when some of the time you feel, oh, well, rules are for fools, let's go out and do something spontaneous because your mood's up, or I'm struggling to do anything now because my mood's down, or, there are these challenges. And so people who have bipolar parents will talk about the environment being quite challenging. Now, to tell the full story on that, they also do talk about positive aspects to that environment, and and how, having had a mum or a dad that's had bipolar disorder, they've experienced things they may not want to have experienced in terms of stress and that sort of thing. But they've also experienced things they say that they wouldn't want to have lost either, in terms of the spontaneity or excitement or whatever.
Right.
But it does mean that it's so in some ways it could be a richer environment, but it's a more complex and challenging environment than you might normally have. And so one of the things we've been looking at is looking at non-stigmatizing ways of helping parents with bipolar disorder around both the bipolar aspects and the parenting aspects, and that's we've got some really positive results around a fairly straightforward web-based support system for that. And one of the reasons we did that was because talking to people with bipolar who are parents, they're saying, yes, on the one hand, there are challenges there, and we don't really know where to take this, because we're really worried if we flag this up with our clinicians, they'll panic that we're not able to parent, whereas actually what we need is a bit of support.
Do we know if there's like any kind of biological mechanism that causes So it's tricky, this causal one, because you've got the onset of bipolar as this kind of a disorder in and of itself, but then you've got these the mood swings, if you like, as well. So is there a biological mechanism behind the triggering of the mood swing from going from normality to depression, swinging up into mania and coming back down again?
Well, I think one of the most reliable findings around bipolar disorder is that is a sort of tendency to or a sensitivity around disruption of the sleep-wake cycle. So that, for instance, circadian rhythms are the basic patterns of sort of heart rate, body temperature, mood, behavior that cycle over a 24-hour period. And in bipolar disorder, there does appear to be a sort of vulnerability to disruptions of that. So for instance, one of the things that people describe living with bipolar disorder is that things like transatlantic flights can be quite a challenge because there's no way of escaping some sort of circadian disruption there, that sort of jet lag feeling. And I mean, in a sense, when people are aware of that vulnerability over time, they can do something about it, so they can make sure they have enough recovery time at the other end. They don't just walk off the plane into a meeting and carry on. But before they're aware of, before it's developed, that can cause problems because people see, other people apparently coping quicker with that disruption, feel they should do themselves, and then their mood either escalates or declines as a result of that sort of disruption. So obviously the scale of circadian disruption can be influenced by, the severity. The severity of it can be influenced by like the sort of time zone travel that you do. So, for instance, going from the UK to the States, that you tend to have less severe disruption than coming the other way, and so where that disruption is more severe, people can have this. I don't know if you've experienced it, but you can have this sort of feeling where you might have kind of missed a night's sleep due to the time zones, and you sort of feel tired, but you also sort of feel revved up.
Yeah, I am familiar with that feeling.
Yeah. So if you think about if you get off a plane and you're experiencing that, and you're thinking, that was a long flight. Oh dear, I need to go and make myself rest, or just sort of. That's one reaction. If you're thinking that is actually a fundamental part of you as a person that's being released by that experience, that's a very different thing, because you'd go with it, wouldn't you? And within bipolar disorder, the tendency cognitively seems to be more to think of those experiences being sort of a part of the self, part of me as a person, rather than, oh, well, of course I feel like that. I've just got off a long flight from Chicago or something. So, I mean, the flight is an extreme example, but if you imagine that sort of in smaller segments in life in general, if you're labeling those as part of yourself rather than part of, what life's throwing at you, you react to that differently. And that can, along with that sensitivity to reward we were talking about, can feed into escalating the sort of changes in mood state we were talking about.
Yeah, so it's the people that struggle with sleep disorders, have they got a heightened risk of developing bipolar?
That's a really good question. So can I just answer that in a sort of slightly different way first, which is that there have been a number of studies looking at people with bipolar disorder that show that people with bipolar disorder are more likely to have clinical levels of sleep disturbance than a lot of other groups. So sleep disturbance is more common in bipolar disorder than in a number of other complaints. In terms of whether people with sleep disturbance are more at risk, I think it comes back to the way, like a lot of these things, how we think about our experiences. So if our model for what's going on as a consequence of sleep disturbance is about thinking about ways of improving sleep, that would be probably not something that would push you in the bipolar direction, so much as if you're experiencing symptoms of sleep disturbance that you're then labeling as things that are fundamental parts of you, you would act in a different way. So taking that example of, that paradoxical increase in energy you can sometimes get when you're tired, that could be, you could be thinking, well, that doesn't feel quite right. I need to just sort of chill out for a bit. Or you could be thinking, right, wow, okay, good. This is an opportunity. What are the things on my to-do list, and let's add a few more, and let's take advantage of this by putting in a few extra projects. And suddenly, you're feeding that sleep disturbance, and suddenly that's feeding your mood. And then often you'll get a few successes because of your drive and whatever, and that feeds that, and then you're on your way. Your mood's escalating, and off you go. So some of the things that seem to be characteristic are the ways people think about those.
Yeah. Right. Okay. So if we kind of moving into the final part of things now, what are ways for people to kind of treat and manage this? Reliable ways to.
Well, so the way things are at the moment is the thing that most people get is some sort of drug treatment, essentially. That's what, if somebody goes to their GP or their first contact with mental health services, that's often the reality is for bipolar disorder if they go in mania. Or
do you have to apply different medications to the mood cycle?
Well, so medication-wise, things are quite complicated because what the sorts of things that work in mania, for instance, so people are often given sort of tranquilizing type medications in mania in the acute stages. That wouldn't be something that's helpful when somebody's not in that sort of state. People are often, people can be given antidepressants when their mood is low. And there's some evidence that there's a risk if you have bipolar disorder that antidepressants can sort of also tip you into an elevated mood state. So it might help your mood recover a bit, but it might also tip you over into an elevated mood state. So there's been lots of research also on, what's the sort of long-term medication somebody could take that would help them avoid episodes and sort of generally help them in a longer-term way. And there's the NICE guidelines, which came out in 2014, indicated that really for sort of that long-term treatment, that lithium is the thing which has the strongest evidence base. So there are a range of drugs people can be offered. I mean, people living with bipolar have very mixed views of how useful those drugs are. So some people would say that lithium has transformed their life, say, in a really positive way. And other people would say that it really makes them feel weird and horrible. And, the side effects of that are worse than their experience of the bipolar disorder.
Right.
So as a result, you have a very mixed picture of what people are doing treatment-wise. So quite a lot of people who are prescribed a particular regime of medication will not be taking it, or will be taking it in a way that they've decided, rather than what the prescription says.
Yeah, I've read that people with bipolar are particularly inconsistent with medication. About 75% of individuals don't take the medication consistently.
Well, I mean,
is that due to the nature of the illness itself, or?
No, I don't think so. Well, I think adherence to medication as prescribed isn't brilliant. Generally,
okay.
I mean, if you did a review of how well, if you or I are prescribed something from the GP for, I don't know, flu or whatever, I mean, most people don't actually take it in exactly the way it's prescribed. And I think talking to people that often what's called lack of adherence by services is people making choices. So a lot of these drugs have, they have an intended effect, which might be positive, but they come with lots of other effects which aren't positive. And so when you've got a long-term issue, I guess you're always calibrating, is the gain I'm getting from this worth the cost?
Mm.
And I think, in terms of helping people with bipolar, I think one of the key questions is having an open discussion about that. Because people do talk about, in a sense, telling their clinicians a story because they don't want to get in trouble. And so, their clinical team doesn't really know what they're doing.
Yeah.
They don't know whether what they're doing is helpful or not. And you end up in this really unhelpful situation. Whereas actually, the evidence is that overall, if you take the sort of population of people with bipolar, there is evidence that, say, lithium can reduce risk of relapse. If you take an individual, it's not true that works for every individual. So there are some individuals where it does and some individuals where it doesn't. And so so treating people almost on a case-by-case basis is important, I think.
Is CBT effective?
Well, there's increasing evidence that structured psychological interventions can be really helpful, of which CBT is one. So cognitive behaviour therapy designed to help people with sort of information about bipolar disorder, coping strategies, managing the sort of thoughts and beliefs associated with mania and depression is associated with kind of better clinical outcomes, including reduced risk of relapse. And there are a number of other forms of treatment that can be helpful. So there's relapse prevention is a sort of a briefer form of intervention based on cognitive therapy principles, where people are, again, in a sense, being supported by a therapist in self-management advice and early warning signs for mood change. And again, that seems to have positive effects. And also group interventions, again, structured along broadly cognitive behavioural principles around living with bipolar disorder constructively seems to have a positive evidence base. And one of the things we're looking at now is sort of looking at some of the things around bipolar disorder that people are saying they want help with. So, for instance, alcohol and substance problems are common in bipolar disorder. Anxiety is a common difficulty in bipolar disorder. Parenting challenges. So thinking, how can we help people with those issues alongside their bipolar disorder? And, what benefits and gains does that give somebody?
Yeah, I imagine it's really anxiety provoking, kind of living in between episodes, kind of just waiting for it to creep up on you and for you to kind of happen again.
Exactly. So some people talk exactly like about those experiences of sort of fear of recurrence and what does it mean to have it. And so it's with anxiety very linked to, if you like, bipolar disorder itself. And then other people just seem to have significant anxiety symptoms alongside their bipolar disorder, in the sense of, fairly clear-cut panic or that sort of thing, where the panic isn't as clearly linked to the bipolar recurrence fear as with some other people. And in both cases, applying sort of appropriate psychological approaches to trying to help people in a more integrated way is one of the things we're exploring at the moment.
Just a couple of quick ones before we close up with the prognosis. Omega-3 fatty acids, I believe they've proven to be effective in some studies, and also exercise as well. I believe that's proven effective with psychosis. So I'm just wondering if it's the same with bipolar disorder. Neither of those have reached an evidence threshold in terms of being recommended by the NICE guidelines. So they're both interesting areas, is what I would say. So I don't think the evidence on omega-3 fatty acids is definitive, but I mean, there are some suggestions it may be helpful, and if as it appears to be, it's pretty benign and has a positive benefit, then that's a good thing. And in terms of exercise, I think, again, there isn't a vast amount of data on it, but it seems plausible that it could be of benefit. So, because one of the issues with people living with bipolar disorder is physical health issues. So setting aside sort of mental health just for a moment, I mean, cardiovascular problems are quite common in bipolar disorder, for instance. And it's not absolutely clear how much that's to do with long-term medication and how much that's to do with diet or other things, but certainly things which help with that, and things like exercise which could help your mood and your physical health, are all things that are, seem to be a sensible part of a strategy, really. And I think one of the key challenges in bipolar disorder is getting to a point where we can where people can match themselves to the things they need, so that they don't get Hobson's choice. You get, you either get this or you get nothing. You get a number of choices, and you're able to work with your clinical team to work out which pattern of those choices is working for you at the moment. So, and I think sort of getting to that point will be really important in sort of optimizing people's outcomes. So is it possible to get rid of bipolar, to go through maybe 1 or 2 episodes and then eradicate it? Or is it a chronic illness that you're kind of forever going to be battling against?
Well, there are some people that have 1 or 2 episodes and never have them again. there are some people who have lots of episodes. I think the complicating factor is that experience of symptom fluctuation that doesn't quite reach episode state. And so
has there been any identification or any kind of making a distinction between those people that have 1 or 2 episodes and then are fine and those that don't? Is there anything identifiable there that's...
I think there are a number of things that could be relevant to that. So, for instance, if you look at people who are in very... I mean, you were saying earlier that there are some sort of ubiquitous things in mental health that seem to be associated with onset of lots of things, and I think that's true. And I think those ubiquitous things like life stress and trauma and deprivation, etc., are also often linked to the severity of the experiences that you have. And I think that in terms of the sort of single experiences, those are relatively uncommon, and we're trying to get more of a handle on exactly what are the characteristics associated with that. And some of those will be context, in the sense that, you know, we talked about the difference between Saudi Arabia and the UK, and if you think about the difference between working on a production line and working as an artist in your own shed, and, you know, there are lots of ways where you could have blips, disruptions to your mood, where in one context that's seen as being interesting and creative and, you know, part of you and part of your talent, and, you know, where you're hanging doors on a Vauxhall Astra or whatever, that's not regarded as, you know, being creative with that is not what they want. So the thresholds for it being a problem vary. So there are factors like the context that you're in, again, which will really influence whether ups and downs of mood, as you're saying, that we all experience, get tripped into being problematic or not by somebody's context. And I think things like people's experience of parenting is going to be really important. So you know, if they get really confused ideas of themselves growing up, that's not going to help if you've got a tendency towards mood instability alongside that.
Yeah, the one kind of worrying thing that I kept reading in different places was that symptoms become more severe over time, or have a tendency to. Is that true? Because it doesn't sound like a very positive prognosis, does it? If that is the case.
No. Well, one of the things we're doing a lot of work on here is trying to look at the bipolar disorder in the round, basically. So I think one of the problems with a lot of the data is around selection bias. So if you think about the way most clinical services are configured, they're configured around really delivering services, the severe mental health services, to people with things like psychosis that are, you know, do change, but they're relatively stable. They're not really designed for people who may come in a manic episode, you know, in a really distressed state, recover relatively quickly and then seem to be fine, but maybe at risk of something in the future. Services aren't really set up for those. So then if you think about following people up in services to see what happens to them over a long time, the risk is that you find really negative outcomes for bipolar disorder, because the people who are still in the services are really unusual people in relation to the people in bipolar in general, most of whom have either withdrawn from services or been discharged.
Right.
So we do a lot of work with sort of, you know, self-referrals into studies and general population surveys and that sort of thing to try and capture both aspects. And so I think there isn't strong evidence that bipolar gets inherently worse with older age, and there's actually conflicting evidence, some of which suggests it gets better and some of which it suggests it gets worse. And certainly in talking to people with who are in middle age and beyond about their bipolar experiences, a lot of them do describe that they continue to have fluctuations and that sort of thing, but their experience of living with it itself is really important. And for instance, knowing that a depressive period will end.
Of course, yeah.
You know, just really knowing that and believing it makes such a difference.
Yeah.
And similarly, being able to pick up beginning the initial changes into mania, and actually, you know, you're kind of familiar with the way it goes.
You can preempt it.
So you can take steps, and so I don't think it's that sort of negative story, really.
Yeah. So given, say, you know, if somebody, I always like to kind of end on a hopeful message, but if somebody can find a combination of the right medication and a decent therapist, maybe combine the two, the outlook is hopeful.
Well, yeah, let me give you an example. I mean, one of the things we're working on is personal recovery in bipolar disorder. So we've got an intervention where we work with people to identify what it is that they want to work on. So they choose whether they want to work on an anxiety or relapse or relationships or whatever. We don't sort of point them in a particular direction. And what we find with that is not only do people benefit in terms of feeling that their personal recovery, their ability to live a positive, engaged life towards things that matter to them has been enhanced, but also things like relapse are improved as well. So even if we're not really focusing on that, because we're sort of helping people to sort of realize what's meaningful to them. And so I think there's a lot of opportunities around sort of developing work in those areas where we're actually taking the strengths people have and working with them to enhance those strengths, where the message is, yeah, okay, you're experiencing challenges, but look at all these assets you've got, and how do you want to apply those in relation to these goals that you've got? And what we find so far is that people really respond to that.
Good. On the subject of stigma, two specific questions I've got. The first one being, so there was a name change. I'm not sure if it was official. So this used to be referred to as manic depression. Has that been an official name change?
Yes.
And do we know if it's had like a positive effect on the stigma aspect?
So there definitely has been a change from manic depression to bipolar disorder, and I think people definitely talk about bipolar disorder more now, and more people who are living with it, who are sort of in the public eye, are coming forward in the last maybe 5 or 10 years. I'm not sure whether that's a general change, because there are more people talking about mental health generally as well. So I'm not sure the name itself has solved that. And I think people living with bipolar have, many people still feel it is a significantly stigmatized diagnosis, and people have really difficult decisions to make, like in terms of, for instance, asking for reasonable adjustments at work and therefore revealing their condition. People are very wary of that because of their concerns about how they would be perceived.
Yeah, just from the outside, before I knew anything about mental health, I did think there were two distinctive disorders, and I do think that the word bipolar is much less emotive. It doesn't really. Manic depression is a very emotive way of putting it, which I don't think is a very helpful one. Whereas bipolar just sounds like a neutral diagnostic term, which I think is quite good.
Yeah, so I think that was the intention, and it's good to hear that that's how it sounds. I'm just reflecting that I'm not, I think there are mixed feelings among people, of course, who that's been applied to, as to how non-stigmatizing they feel it is.
Yeah, the second one is very directly, are people with bipolar more dangerous than members of the general population?
No. The big risk for people with significant mental health problems, bipolar being one of those, is their vulnerability, not their risk.
Yeah.
So the big risk is that people may get a little disinhibited, or they may not think through their alcohol consumption on a Saturday night or whatever, and get into situations that make them vulnerable, or trust people, or gamble money. There's no good evidence that bipolar disorder is inherently related to greater risk than being a member of the general population.
Okay, Steve. My quick fire questions.
Okay.
I'll try and get through these as quickly as possible. Firstly, do you have any book recommendations on this topic for people?
I think the nice guidelines for bipolar aren't necessarily a fun read in a sense, but they're full of really good summaries of what should best practice be in terms of medication, in terms of support for families, support for the individual. So I do think, and that very digestible versions of that are available on the NICE site. So I'd recommend that.
Have you got your own book? You can plug that if you've...
Well, I with my colleague Fiona Lobban and Anne Cook in South East Thames wrote or coordinated Understanding Bipolar, which was a report for the British Psychological Society. And that basically maps out the importance of considering a psychological perspective in relation to bipolar disorder in general. So that some of that's about treatment, but some of it's about how we think about bipolar disorder. For sort of self-help, I've written a book called Coping with Bipolar Disorder, which is a kind of simple guide. So, yeah, there you go.
Okay, I'll include links in the show notes for that. If you could have unlimited funding to research anything you liked, however niche, however bizarre, what would it be and why?
I think it would be to expand what we've been doing already, really. So what we've been trying to do is get to a point where people living with bipolar disorder have access to interventions that build on their strengths and have choice in those interventions that match the intervention to their needs rather than match it to the way the services are configured. So if I had infinite resources, it would be to research and implement a menu of options for people living with these conditions so that they can be supported to make the right choices for themselves. Because I think, it's not rocket science to think that if you can engage people with things that make sense to them, the outcomes are always going to be better.
What, if anything, keeps you up at night?
I think one thing that keeps me up at night is frustration with getting the story out there that the psychological dimension to bipolar is really important. Not just as in a marketing plea from a clinical psychologist, because a lot of the psychological dimension issues are to do with how you approach somebody in terms of whatever treatment you're offering them. But I think, there's a long way to go to make that centre stage, really.
What mistakes do you continue to make despite knowing better?
In life or in research or what?
Whichever sprang to mind first.
I mean, I think the interesting thing about being an academic is it's almost about making mistakes. So in a way, because it's about having ideas and testing them and finding some of them are right and some of them are wrong and sort of going with the data, which sounds obvious, but, obviously a lot of ideas, you may have put years into those, and embracing the fact that sometimes you're just wrong
yeah,
is really important in moving forward. But It would be a lie to say that's not challenging.
What part of your career are you most proud of?
I think what we're doing with the Spectrum Centre, really, in terms of, we've set something up where we're working towards an aim, which I think is really good. We're involving people with the condition in, as far as possible, all aspects of that, and we're still managing to sort of get money and move it forward. So that.
Final two. Outside of family and academia, what investment of time or money has brought you the most joy or fulfilment?
Well, I think going back to exercise, really. So cycling from coast to coast with my father on his 80th birthday, followed a month later by doing it with my son on his 15th birthday, was just amazing.
Yeah, that sounds amazing.
Nearly killed me as well.
Okay. What do you think is the key to happiness?
Well, I wouldn't claim I know, but I think one thing that I feel I have learnt from, I've obviously talked to a lot of people with a lot of challenges over the years, and I do think that there's a lot. Psychologists and psychiatrists and other academics, we can spend a lot of time complicating things sometimes. Not with negative intent, but it's just, we're academics. What can you do? I mean, I think one of the things that really impresses me with is people's kind of resilience to just keep on going. And so whilst it doesn't sound very technically complicated, actually I feel I've learnt a lot from people just about the importance of that, and that actually happiness is important, but hanging in there is really important, because happiness comes and goes, and it would be a weird thing if you had too much happiness. And in fact, mania used to be regarded as disordered happiness. So
you need the contrast.
Yeah.
Steve Jones, thank you very much.
Thank you.
Okay, if you'd like to comment on this episode, you can do so by going to myownworstenemy.org/podcast. That's also where you'll find all the show notes and links to any relevant information. If you'd like to support this podcast, you can do so by leaving us a positive review on iTunes or just sharing your favourite episode with your friends and family on social media. If you'd like to contact me, I'm Danny D. Whittaker on Facebook and Twitter, or you can send me an email to danny@myownworstenemy.org. And until next time, behave yourselves, but not too much, and I'll see you again next time.